Hello and welcome to Health Affairs This Week. I'm your host, Jeff Byers. We're recording on May 1st, 2025. Just a heads up, if you haven't already heard, we have an insider event happening on May 29th. It's on the FDA's first 100 days under the second Trump administration. It's going to be moderated by Rachel Sachs, and the panel will include Richard Hughes IV and Artie Rye. Today, I'm joined by Aledade co-founder and CEO, Farzad Mostashari. Before starting Aledade, Farzad helped usher in the use of electronic health records in the healthcare setting as National Coordinator for Health IT. He's always had an active social media presence, from what I can tell, and I saw him reflecting on the latest MedPAC report on value-based care on X and LinkedIn, respectively. So it sounded like he had a lot on his mind, so I invited him to discuss these topics and more. Farzad Mostashari, welcome to the program.
Glad to be here.
Thank you. Yeah, thanks for joining us. So this is somewhat a pedestrian question, but I have to assume that every episode could be someone's first, and every episode could be someone's first entry into health policy. So when I was a business reporter, I never really saw any clicks on this topic. So I wanted to ask you, why is the MedPAC report important?
I mean, I'm always shocked at how good it is and how full it is and what good kind of honest, not overly fussy analyses, but pretty honest and down the middle. And they blend the reporting of what you can be observed, and in some cases using data that only they have access to, with what should be done. So I'm mystified why everybody doesn't read the MedPAC report the second it comes out. I can't help you there.
Yeah, well, what is the MedPAC report?
Yeah, it's the Medicare Payment Advisory Commission. Their job is to make recommendations to Congress. Actually, one of the things that I didn't understand when I was in the administration, I thought they were talking to us. Turns out that by law, by statute, they're not really talking to CMS. They're talking to Congress. But obviously, policymakers pay a fair amount of attention to what they say. And I gotta say, under Chernow, more so now than perhaps in a decade ago, I think MedPAC has spoken more clearly, and I think that has helped actually not kind of hiding the ball as much in kind of technicalese, but doing mic drops like like the STARS, the quality program is broken. We have no idea whether it measures quality or not. That kind of.
Mm-hmm. And then they just walk away.
Exactly. They're like, fix it, Congress.
Yeah. Well, you posted a tweet storm. I don't know if we call them tweet storms anymore, but anyways, posted a tweet storm. What are some about the MedPAC report, the latest one? What are some of the biggest takeaways of that report that you took from looking to future healthcare policies?
Yeah. So the areas, I mean, obviously it's a huge report. It covers a lot of stuff that I have no particular insight into. But the areas that I focus on is what they say about primary care, what they say about alternative payment models, what they say about Medicare Advantage, and then competition consolidation. So those are the kind of the four areas that I know something about. And so I kind of pay pretty close attention to. I think on primary care, the kind of key insight there was around just how fee-for-service is a losing game for primary care. And they keep trying to help, right? And now they're trying to, do a safety net add-on policy, and that's going to help increase the fee schedule by 5.7% for primary care clinicians. And they're just, even though they recognize it, they're just trying to patch what fundamentally they recognize it doesn't really work for primary care, that primary care is consistently paid less than the value that they could be creating in the system. The other thing that they talk about is the kind of average payments for clinicians. And they say, clinicians are paid 140% of Medicare by commercial plans. What's interesting is that that's an average. And what I wished they would actually do is look at the price transparency data that health plans are now required to post and just see how much variability there is around that, because there are plenty, let me tell you, of independent primary care practices who are paid at or below 100% of Medicare. And so I think the report does focus on the adverse effects of consolidation, but I wish they would take it actually that next step forward and break out independent primary care practices versus kind of the payments that are made to health systems for primary care, much of which never flows down to primary care. Even if you increased primary care fee schedules, it never makes it to the primary care docs. It gets kind of absorbed by the system.
And is that a kind of result of consolidation?
Absolutely. It's not only a result of consolidation, it's a driver of consolidation. Because when you underpay primary care who's independent on the commercial side, right, they then get bought up by health systems who not only charge more for those services, but now they have kind of the captive in terms of the referrals, the scans, the in-house services that further consolidates and increases their market power and their leverage. So I do think we have to take competition and consolidation very seriously.
Yeah. We've had a lot of episodes on consolidation as well. There's a lot of research from the pages of Health Affairs on consolidation as well. You talked about Medicare Advantage, and one of the things I wanted to ask you about, there's a lot of news, studies, just like maybe potential criticisms of Medicare Advantage these days. What did you see in that area in the MedPAC report?
Yeah, again, I really appreciated their like very cool, balanced, like they're like, look, we pay more for when a senior joins a Medicare Advantage plan. The idea had been that the government saves money. In fact, the government spends more. So that's a fact. And they go on to describe the portion of that that's due to risk adjustment, the portion of that's due to selection effects. But they also they're not trying to be advocates. They're like, look, and seniors get more, right? Like because of the increased payments, the MA plans offer benefits that patients in traditional Medicare don't have. And there's some evidence of, particularly in value-based models, of lower ER and acute care utilization and so forth. So I think they're trying to strike a pretty good balance in talking about it. And I think it's the details are where I think it gets interesting, right? Is like what should be done for this. And so, for example, one of the things they point about to is that there isn't guaranteed issue for MedSup once someone switches from traditional Medicare to Medicare Advantage. There are some states that have it, but if you wanted to create more choice, perhaps you would extend that guaranteed issue for MedSup so people go to MA, they could go back to traditional Medicare with the MedSup plan, make that more feasible. They also talk a bunch about risk adjustment, and I think it's a super complicated question of what to do. But I thought there were 2 points that actually Abe Sutton, who's now the CMMI director, made very well as well, which is one, that there isn't just a problem with overpayment with risk adjustment, but what MedPAC calls heterogeneity, meaning some plans are a lot better at this than others. And then that creates downstream effects that those plans that are kind of the sharks against the guppies are able to offer more benefits and grow more and have higher margins and have more consolidation, right? So it's not just enough for the government, for example, to increase the coding intensity factor and claw back some of the overpayments on risk adjustment. If you simply increase the coding intensity factor, you'll actually exacerbate the sharks versus guppies. You'll drive more of the plans who don't focus on risk adjustment out of the market, out of business, and you'll increase consolidation. And so they're calling for things like, looking at in-home assessments as something that might be a specific policy that would help, in a sense, level the playing field.
Yeah, I'm glad you touched on that because I did want to ask you about risk adjustment and quality measurements. You had mentioned that there's a window of opportunity now to reform quality measurement. Can you drill down into that? Like, why is that window now? And like, what can be done about it? I mean, you kind of talked about what can be done about it, but like, why is the opportunity now?
Well, I do think that the Overton window of what's possible is just wider today. And I think the opportunity now to substantially reform quality measurement, not only to bring more meaning to it, but also to reduce the cost and the burden of data collection, to remove these silly cliff effects, to focus more on outcomes. That was actually one part where I thought the MedPAC report, a little bit, they were like, they got tired. And at the end, just kind of like mailed it in, and they were like, so anyway, what we said before. And I'm like, no. Now's the time, because I do think they just say, like we said in June of 2020, Congress should replace the current MA quality bonus program with a new MA value incentive program that scores a small set of population-based measures, evaluates quality at the local market level, and establishes a system for distributing rewards with no cliff effects. So yes, but let's get more specific. And I think in particular, this is the time where delete might make sense to folks in the administration. And if there are measures, we published an article talking about the medication adherence measures, and they don't make sense anymore. Like, we have blood pressure control. We don't need a medication adherence for blood pressure control measure that is triple weighted, that is topped out, that is frankly roughly uncorrelated with actual blood pressure control. Like, we don't need that measure anymore. Delete it. So I think there's a lot of the window's open now to make bigger changes than would normally be possible.
Well, thanks for laying that out for the MedPAC report. That helps me learn a lot. Again, I didn't know that much about it, so hopefully the listeners learned something as well. You published a piece on LinkedIn outlining some thoughts on value-based care in an article published in New England Journal of Medicine. And it made me wonder, you're instrumental in crossing the chasm for EHRs. There are financial incentives there. But for value-based care and the adoption of AI in healthcare, what are the similarities and differences between the adoption of EHR and value-based care?
So when I joined the administration in 2009, it was pretty rare for docs to be on an electronic health record. Like 1 in 5 was using it. And by the time I left 5 years later, 1 in 5 was not using it. So we got this kind of fundamental flip, right? From only early adopters to basically only late adopters not having it. What happened there? And we took some lessons from that with the author of actually the kind of seminal business book, Crossing the Chasm, Jeffrey Moore. And some of the things that we outlined in that one was, it's not just about financial incentives. I think I was actually talking to a doc who said, there was a mandate to switch to EHRs. And I was like, well, do you remember what the dollar amount was? He was like, no, I don't. I was like, it was $9,000 a year. This is a doc who's getting a check for over $100,000 from us for value-based care, right? For the size of the financial incentives for primary care to adopt value-based care is so much bigger than what the financial incentives were for EHR adoption. So it's not that, right? It was, we created a sense of inevitability. We spoke really clearly about, we want, like, paper kills, right? EHR is better than paper, right? And I think there's a little bit of opportunity in CMS, who controls both the fee-for-service side and the alternative payment side, to say, we think unmanaged fee-for-service is bad. We think it's bad. We think everybody should get out of that, and we want all primary care docs in an alternative payment model. I mean, Congress kind of said that in macro, and I think CMS didn't really follow through with that. There were no penalties really for the low performers, and they didn't really make fee-for-service uncomfortable. So I think there's an opportunity there. The other thing that we talked about is, don't keep shipping bells and whistles. Like, the more new programs you have, in a way, the more you confuse the issue. There was one meaningful use program, period. We want you to do meaningful use. And right now, every time, honestly, CMMI introduced a new model, it confused people as to what they're supposed to be doing. And our strong recommendation is, focus on the Medicare Shared Savings Program as the chassis, and encourage everybody to join that for primary care at least, and focus CMMI on specialty models. That's where we need more experimentation. Great. When it comes to primary care, we have the chassis. It's the Medicare Shared Savings Program. And then, removing the obstacles, but also simplifying it. And in the case of the electronic health record, it was pretty complicated making that decision. And co-founder, actually, Matt Kendall, set up 60 regional not-for-profit extension centers that helped primary care docs adopt the technology. 133,000 primary care docs made the switch successfully to meaningful use through those regional extension centers. We spent $1 billion on that in the federal government, and that was money extremely well spent, right? That's what essentially Aledade is trying to do. We and other enablement partners are trying to be the simple button for this transformation, where the docs don't have to try to figure out the technology and the data and the rules and the policies and the regulations and the playbook. And we just say, hit the easy button and we'll help you get there. But there isn't really a program the way there was with EHRs for CMS to explicitly acknowledge and enable and empower those enablement partners.
Yeah, well, I'm glad you brought up your work with Aledade with that, and also the regional extension centers, which also reminded me of like how much of a coordinated effort that is. How is that work getting people to take the journey with whether it's technological advancement or how payment is changing in healthcare?
Yeah, I mean, look, we bring in more people into the Medicare Shared Savings Program than anybody else. We added 500 new practices last year into the Medicare Shared Savings Program, and 80% of those were new to the program. They weren't coming from one group to us. And so we know a lot about what those practices are looking for. And one of the things they're looking for is stability, and they're looking for the proven solution, right? And so the fact that we've been around 10 years, the fact that we have a demonstrated track record, and they can find others in their neighborhood who have joined and have been successful, I think is a big part of it. But it's also kind of the feeling of trust. And being an independent practice is hard and getting harder. And when there are disruptions like COVID, like the Change Healthcare attacks, like a hurricane, those are the times when both people realize fee-for-service is not a great way to run a business when those disruptions happen, but also that they feel alone, that there's no one advocating for them. There's no one on their side. There's no one looking out for them. They're not part of anything bigger, and they don't want to be consolidated, right? They don't want to have someone else take over their clinical autonomy, take over their schedule, take over their, push them on RVRUs. And there was actually a very interesting section in the MedPAC report that talked about why they sell themselves to practices. And they basically say they sell themselves to hospitals because the payer rates are low, but they don't get more pay. They see fewer patients. They have less autonomy. They don't like being unproductive, and they hate being micromanaged. That's the summary of the evidence of consolidation as it affects these independent practices. And I think what we offer them is a way to stay independent, but be part of something bigger.
I remember back in the day, I can't remember if it was an ACO. Yeah. Talking about ACOs, I think there was something like, you've seen one ACO, you've seen one ACO. So have we come to a central definition of ACOs, and how do they actually save money?
There actually was a recent article in JAMA that did a follow-up study on ACOs and in the Medicare Shared Savings Program, and the evidence is strong and getting stronger every day that they are saving money, and the more independent ones, the non-hospital ones, are saving more, and it is billions of dollars that are being saved. And in terms of like how they're doing it, there are some differences, but the one commonality is primary care access. And I appreciate the MedPAC for trying to say, like, look, seniors can access care in Medicare. But according to the data they showed, Medicare beneficiaries, 52% of them said they had a problem finding a primary care provider who would treat them. 52%. So the MedPAC compared that to commercial and said, hey, it's not bad. And I'm like, yeah, well, but for a senior like my mom, who's 80 years old and has multiple chronic conditions, like having to wait many weeks to see 22% had to wait more than 8 weeks for their next primary care appointment. Like that is a big problem. And if there's one commonality between different approaches for accountable care that work, it's just access. Just elderly seniors with multiple chronic conditions need to be able to see a primary care doc who knows them, who knows their conditions, who knows what's happening with them, and cares about preventing them from ending up in the hospital, and says to them, look, call us first before you go to the ER, as opposed to when you call the number, it says, go to the ER, you got a problem. And I think that is, it's like the big difference in how more prevention, more primary care leads to better chronic disease management and fewer acute care complications.
Great. So Farzad Mostashari, as we wrap up, you're a physician, a researcher. You were the national coordinator for health IT, and now business owner with Aledade. Had a question. You mentioned that Aledade has been around for 10 years now. Coming out of government service and physician and research, people like to say, making a business in healthcare is hard. You've done it. How hard has that been building a business? What was harder than what you expected? What's been easier than you expected?
I guess I would say the continuity for me from 10 years as a public health person in New York City, 5 years as a federal policymaker, now 11, 12 years running this public benefit corporation, Aledade, the commonality has been more than the differences. It's about setting the vision for how do we save the most lives, has been the kind of the animating theme, and finding different approaches to that. But at the end of the day, setting that vision, inspiring and motivating people to climb on board, believe in that postcard of the future, and then using, honestly, technology and creativity and financial alignment to try to find our way there. It's not a straight path, but it is the most meaningful work we could do.
Well, that's a fantastic place to wrap up. Farzad Mostashari, thanks for joining us today on Health Affairs This Week. And if you, the listener, enjoyed this episode, please send it to a friend. With that, have a great rest of the week, and we'll see you next time.